Hello and welcome back to the Academy of Anesthesia. In this series of videos, we will be tackling the topic of vomiting. This question comes up often in both the primary and the final FRCA. Vomiting is one of the commonest side effects of anesthesia. Its incidence is often quoted as 30% in the general surgical population. It's also reported as a side effect that's associated with the most patient dissatisfaction, and therefore it's something that we do need to consider when giving an anaesthetic. This will be a 3-part series, where in part 1 we will cover the physiology of vomiting. In part 2 we'll go over the pharmacology and the classification of antiemetic drugs. And then finally in part 3 we'll discuss the risk factors, antiemetic strategies, and the current guideline recommendations to cover the clinical application of this knowledge. Let's get started with the physiology then. Here is a simplistic diagram of the central nervous system. Focusing on the brainstem, you can see the structures we will discuss today are closely related. Vomiting is often described as a reflex, and so you can divide the different components involved into sensors, integrators, and effectors. The sensors are the receptors located in various parts of the body, particularly the Chemoreceptor Trigger Zone. This lies in the floor of the fourth ventricle and is outside the protection of the blood-brain barrier. The integrator of these signals is the Nucleus Tractus Solitarius, which is located close to the Chemoreceptor Trigger Zone in the medulla. This integrates the signals and sends a message to the central pattern generator, the effector. The central pattern generator is a network of structures in the brainstem linked to rhythmical movements. Think of it as similar to the pain matrix. It's sometimes called the vomiting center, but this implies it's a discrete structure rather than a network of structures, and it's also a slightly outdated term. We'll use the sensors, integrators, and effectors model to describe the details underlying the physiology. Let's create a flowchart first and add the central parts such as the Nucleus Tractus Solitarius, the central pattern generator, and the Chemoreceptor Trigger Zone. The shapes I've used for these will make sense later. The areas which contain sensors or receptors include the higher cortical areas, the limbic system, the pain pathways, vestibular apparatus, the GI system, and baroreceptors. Higher cortical centers can detect increases in ICP or respond based on visual or olfactory senses. Areas like the limbic system send signals based on perception of fear, pain, or anxiety. These are why you feel nauseated if you're watching a horror film. You're anxious, scared, and there may be something repulsive being shown in the scene. Peripheral pain pathways can also trigger vomiting from pain, obviously, but also from histamine H1 receptors, as well as through activation of the limbic system. The vestibular apparatus, which is responsible for balance, contains histamine H1 receptors and cholinergic muscarinic M1 receptors. These are what make you feel sick after a roller coaster ride or what gives you the feeling of motion sickness. As we've mentioned before, the chemoreceptor trigger zone lies outside the blood-brain barrier, therefore it's also exposed to toxins in the blood directly. The GI system sends signals directly to the Nucleus Tractus Solitarius. In the GI tract, there are mu-opioid receptors, 5-HT3 or serotonin receptors, and stretch receptors. It can also detect the presence of certain toxins. These are important at making sure anything ingested orally gets sent back out if the body detects it as harmful. We already discussed baroreceptors in the previous video. They also send signals directly to the Nucleus Tractus Solitarius in response to low blood pressure to cause vomiting. Both the GI system and the baroreceptors send these signals via the vagus nerve. Finally, you have the chemoreceptor trigger zone, which has the most types of receptors. They include the 5-HT3 receptor, the dopamine D2 receptor, mu-opioid receptors, cholinergic M1 receptor, and neurokinin or NK1 receptors. Serotonin, neurokinin, and opioid receptors are also located in the areas of the Nucleus Tractus Solitarius. Now, the reason why the CTZ is a pentagon is to help you remember that there's 5 types of receptors and 5 inputs. And the Nucleus Tractus Solitarius is a triangle because it has 3 types of inputs and 3 different types of receptors. It's just a little aid to help you remember for the exam. The Nucleus Tractus Solitarius will relay the signals to the central pattern generator, which will trigger the vomiting reflex. It's safe to say that the more receptors that get activated, the higher the risk of vomiting, but whether or not these are additive or synergistic is probably an oversimplification, and there's likely a complex interaction underlying all this physiology. Nevertheless, when the vomiting reflex does get activated, the relevant cranial nerves and spinal nerves also get activated. These are cranial nerve 5, 7, 9, 10, and 12, as well as the phrenic nerves and various spinal motor nerves. The actual process of vomiting can be divided into two phases, the pre-ejection phase and the ejection phase. If you read some sources, they divide the process into three stages, the pre-ejection, the retching, and the ejection phase, but the RCOA official revision notes only include two phases, so that's what I'm going off. Overall, both types of classification include the same steps, so it really doesn't matter as long as you have a logical method of describing the process that the examiner can easily follow. In the pre-ejection phase, muscles of the small intestine contract in a retrograde fashion, and therefore the contents of the small intestine will be pushed back into the stomach. Then there is the secretion of saliva in the mouth, which is rich in bicarbonate, or HCO3-, which will prepare the mucosa of the mouth to be protected from the acid that's about to come back up. For the ejection phase, I'm going to add an airway section to this diagram. You'll have to forgive my crude drawing of the larynx, and I'll just move it to the right to create a bit more space. The ejection phase includes airway protection and the expulsion of contents. So when a person vomits, to avoid it entering the trachea and the nasopharynx, the following coordinated actions occur. First, the larynx and the soft palate are raised to protect the airway. After a deep inspiration, the glottis closes, and then the diaphragm and abdominal muscles contract forcefully. This creates a huge spike in the intra-abdominal pressure. This pressure squeezes the stomach, and whilst the lower esophageal sphincter and the upper esophageal sphincter relax, this allows the contents to be expelled. The parasympathetic nervous system plays a major role in facilitating this whole process, specifically the vagus nerve. To see its effect in real life, next time you're in a C-section and the patient vomits, amongst the other things that you would do normally, pay close attention to the heart rate. You might notice a profound bradycardia that precedes the vomiting reflex, which is the overwhelming activation of the parasympathetic nervous system. Following the vomiting, you can see a tachycardia, which is due to the increased sympathetic activity from the stress response. It doesn't happen in all patients, but it's more likely to happen in young, fit and healthy individuals who have a competent physiological reflex, such as those undergoing C-sections. And when it does, you can predict when you're going to need a vomit bowl and another antiemetic. And we'll conclude it there with part 1. We divided the physiology of vomiting into the senses, an integrator, and an effector. The most important structures to remember are the Chemoreceptor Trigger Zone, the Nucleus Tractus Solitarius, and the central pattern generator. If you remember these three key structures, you can hook on all the additional details as you read further. As with all the physiological processes, this is an oversimplification and is for explanatory purposes, but there will be undoubtedly a complex interplay underlying the physiology. The diagram here is a compromise between the explainability and the accuracy of the process. I look forward to seeing you in the next part where we will cover the classification of antiemetic drugs and the pharmacology. I hope you found the video useful, and thank you very much for watching.